Welcome to the Old Dominion EMS Alliance 2015 Protocol Update Training. We would like to thank our regional medical directors and the pharmacy committee for their time, expertise in evidence-based treatment practices, and dedication to providing care to our patients. We'd also like to extend thanks to Rachel Dillon, Program Coordinator, and Holly Sturdivant, Special Projects Coordinator, for their countless hours editing and tweaking the protocols into their current form. It is assumed that you are already familiar with the ODEMSA protocols, so this training will only cover the changes made to the regional protocols for the 2015 edition. First, we're going to cover some ALS-related changes, some new drugs, taking away a couple of drugs, and some changes in drug dosing. Then we'll cover some protocols that affect all providers, including the BLS medications, stroke, alerts, BFAST exam, and the field triage scheme. Hypoglycemia, D10 is now the preferred way to administer IV glucose. There will be two 250 milliliter bags of dextrose 10%. This will replace D50 and D25 syringes. D50 and D25 will be used as a backup when D10 is not available. All patients over 40 kilograms should be given a 100 milliliter bolus to treat hypoglycemia or altered mental status with unknown cause. Recall that a percent solution is grams over 100 milliliters, so 100 milliliters of dextrose 10% contains 10 grams. Patients under 40 kilograms should receive 5 milliliters per kilogram up to 100 milliliters. Neonates, those under 1 month of age, should receive 2 milliliters per kilogram if hypoglycemia is suspected. The reasons for the change are documented in the medical literature. You're less likely to overshoot your patient's glucose levels. With D50, which is 25 grams, we see a spike over 120 after we give the medication. You're less likely to see skin necrosis during extravasation. You don't need a large bore IV to administer D10. With D50, you typically need that 18 gauge needle to push it safely. And there's no need for an extra step when administering the medication to pediatric patients. You may have a concern in the recovery time or the time it takes from altered mental status back to baseline for hypoglycemic patients, but in a study of D10 versus D50, there were actually no change in the recovery time for those patients. So you're going to administer D10 by attaching your 250 milliliter bag to an IV and administer 100 milliliters of fluid. Repeat as necessary after careful reassessment. For pediatric patients, we do recommend that you use a stopcock and a syringe to draw up a precise dose and administer by IV push. As with any IV medication, always monitor for signs of infiltration before, during, and after. Dexamethasone is replacing prednisone as the primary steroid in the ODEMSA medication kits. The literature does not show any preference over one steroid. Dexamethasone was selected because it can be administered by multiple routes, IV, IM, or even PO. This gives us an option to administer steroids to pediatric patients without the need to start an IV or try to get them to swallow a pill. The medication reference for dexamethasone is available in the ODEMSA protocols, medication 13-9. The mechanism of action is an anti-inflammatory compound. The indications for dexamethasone are for severe asthma and when you suspect croup in your patient. Do not give Dex to those with known hypersensitivity or to patients less than 2 years, although we will allow administration for Dex in your patient from 1 to 2 years old in certain circumstances, and we'll talk about those. The precautions are listed here. The dose for both adults and pediatric patients is 0.6 milligrams per kilogram up to 10 milligrams. The medication can be administered by slow IV push, 3 to 5 minutes, or IM injection, or PO. To give PO, mix the dose into 3 to 5 milliliters of juice or medication syrup. Avoid larger volumes so that you can assure that the full dose is administered. Please note IM injections of steroids are painful, so IV or PO are the preferred route. Side effects of dexamethasone are listed here. After administering dexamethasone, be sure to reassess blood pressure and reassess lung sounds for the development of pulmonary edema. If possible, monitor the patient's EKG and recheck blood glucose. There were also some changes to relevant protocols related to dexamethasone. Protocol 3.3, the adult allergic reaction anaphylaxis, had two major revisions related to steroid use and epinephrine. First, steroid administration was actually removed from this protocol. There no longer is routine administration of steroids in these patients. There was no evidence that this improved patient outcomes, so it was removed from the protocol. Also, the max dose of epinephrine for anaphylaxis for adult patients was increased to 0.5 milligrams. Protocol 911 is the pediatric respiratory distress protocol. For patients that are wheezing and they're over 2 years, administer dexamethasone at 0.6 milligrams per kilogram up to 10 milligrams. Studies show that pediatric patients with asthma benefit from early steroid administration. For a patient with croup is suspected, for example, if they have that barking cough, administer dexamethasone. You can give these patients from 1 year and above dexamethasone, again at 0.6 milligrams per kilogram. Again, here's the dosage for dexamethasone, and we have included in the protocols a chart with the dosages. Due to shortages, you are probably already seeing norepinephrine, Levophed in the drug boxes, but this is going to become the first tier medication for the medication kits. When Levophed is not available, dopamine will be supplied, so that will be the second tier medication. Indications for Levophed are to increase systemic vascular resistance during some shock states to increase blood pressure. This is supplied as a 4 milligram per 4 milliliter vial. To administer, inject 4 milliliters into a 250 milliliter bag of normal saline. This makes a concentration of 16 micrograms per milliliter. For adults, attach a 10-drop set. This just makes the math easier. And calculate your drip rate based on the patient's weight in kilograms. The therapeutic dosing range is 0.1 to 0.5 micrograms per kilogram per minute. And of course, we're going to titrate to the desired response. A dosing chart is included in the protocols. Note this chart is based on a 10-drop set, so just be aware of that if you're using a 15 or even a 20-drop set. Additional training for norepinephrine is available on the Odemsa website. A few cautions when using norepinephrine. Remember, it's not for hypovolemic patients. As with all pressors, make sure that you fill the tank and ensure that there's adequate volume before administering. Norepinephrine can cause tissue necrosis, so make sure you have a free-flowing line and there's no sign of infiltration. And of course, monitor for cardiac dysrhythmias. Vasopressin is now only made by one manufacturer, which has increased the price. In addition, it has a short room temperature stability. As a result, the medical direction and the pharmacy committee have voted to remove it from the drug kits. Epinephrine 1 to 10,000 will be the only option in the drug kits. Magnesium sulfate has also seen shortages over the past years. Some pharmacies have been stocking only 2 vials, but this is going to become the official par level for the drug kits. As a result, Protocol 610, the hypertension and eclampsia, has been altered. 4 grams is still the preferred dose, but the protocols have been lowered to 2 to 4 grams in case you don't have another drug box available. The pain management protocol is also changed to emphasize intranasal route administration of fentanyl. There are no documented cases of chest rigidity by the administration of fentanyl intranasally. The max dose for fentanyl is also increased to 100 micrograms. Pediatric pain management protocol is also changed to reflect a max dose of 100 micrograms. The changes to the drug kits will be made on a rolling basis as you exchange them during their normal use. Please don't take your kits to the pharmacy specifically to change out for the 2015 medications. We anticipate these kits to be changed over by December 1st. At that time, if you still have any kits that have been changed over, please contact Rachel Dillon to make arrangements with the pharmacy. So next we're going to cover protocol changes pertaining to all providers. You will see some changes to the protocol titles, and this is done to match the names in the VFib version 3 data dictionary. These name changes will allow for more improved data collection. Most of these names match the old names, but when they don't, we've included them in the parentheses. The next revision, these old names are going to disappear. BLS providers are now going to be allowed to give Narcan and albuterol Atrovent. Please remember that BLS providers cannot do this skill until they've had adequate training and they're approved by their OMD. We will provide some additional training on the ODEMSA website, and of course the agency can make their own in lieu of this training. Protocol 3.5, the CVA stroke protocol, was changed. Step 5 was updated to include the term stroke alert when contacting the receiving facility. The term was accepted by the Stroke Steering Committee as a universal term that will set off the hospital's own internal process when preparing to receive a stroke patient. Step 8 of the stroke scale includes the BFAST exam. The BFAST scale has been selected by the Stroke Steering Committee to help catch posterior strokes that we were missing with just the regular FAST exam. This includes B for balance. Is there a sudden loss of balance or coordination? E for eyes. Is there any sudden vision changes? Is there any blurry vision or unable to track with your eyes? And then, of course, FAST is face, arms, speech, and time that we've been familiar with. The PDC, the Professional Development Committee at ODEMSA, is developing a quick tutorial on the BFAST exam, so there will be some additional training with the BFAST tool. Included in the 2015 protocols is the regional field triage scheme, which was approved in December 2014. This includes language of a level 2 trauma center in our area. This is a closer look of the field triage scheme. As always, a patient that has an unstable airway, an obstruction, uncontrolled bleeding, or in cardiac arrest should be taken immediately to the closest facility. Steps 1 and 2 represent the most serious injured patients in the field. These patients should be taken to a level 1 or a level 2 trauma center. Step 1 takes into account vital sign information such as the GCS, systolic blood pressure less than 90, or respiratory rate less than 10 or greater than 29. Step 2 takes into account the anatomy of the injury. So these injuries in the box should be transported to a level 1 or a level 2 trauma center. For patients that do not meet criteria in step 1 or 2, step 3 considers mechanism of injury or evidence of high-speed impact. For example, the death of a passenger in the same compartment. Patients meeting this criteria should be triaged preferentially to a level 1, 2, or 3 trauma center. The fourth step takes into account any special considerations. Children age 0 through 14, burns, or amputations with the possibility of reimplantation should be triaged to a level 1 trauma center. Adults over 55 have an increased risk of death with injury, so triaging these patients to a level 1, 2, or 3 trauma center should be considered, especially when the systolic blood pressure is less than 110 in patients over 65. Patients with anticoagulation or bleeding disorders, pregnancy over 20 weeks, end-stage renal disease should be triaged to a trauma center. If none of these conditions are met, the patient can be transported to the closest appropriate facility. The EMS provider can decide to triage the patient to a trauma center at their discretion. This concludes the 2015 protocol update. You can obtain an optional certification of completion by going to our course website at odemsa.coursesites.com. Click on the 2015 protocol update. You take a short quiz. This is optional, but your agency may require you to provide evidence of training. The certificates can be printed or downloaded. Agency leaders can also contact ODEMSA for a verification of completion. Thank you for viewing the 2015 protocol update.